Well, it's a great pleasure to be able to speak to you today about early intervention in rheumatology. We have many of the same issues that you have in dermatology, and we work very closely with our dermatologists. And the same principles we've applied to rheumatoid, we're now applying entirely to what we call psoriatic disease and early psoriasis, pre-psoriatic arthritis. These are my disclosures. And for rheumatoid, when I started, we had a very different attitude to what we should do with our patients. It was a watch and wait policy. You had to earn your disease-modifying anti-rheumatic drug. We now have a much more aggressive, often remission induction policy, and certainly a treat-to-target policy. So I'm going to go through what the expectations were and whether they've been realized or not. In the 1990s, and actually a little earlier, I became very evangelical about treating patients early in the disease process, and particularly focusing on the need to get patients into remission, and also mimicking what the oncologists already did, which was to induce a remission with the disease and then maintain it on less therapy. And so what I'm going to be talking about is early intervention. And as I said, the initial premise was to treat early to avoid damage. Other subsequent advantages of this early approach were that you would get higher remission rates, an ability to taper and even stop drugs, and we would avoid resistant disease. And then talking a little bit about what we do now mainly, which is actually trying to prevent the development of rheumatoid arthritis. And ideally, this is guided by biomarkers, which are objective measures of the disease process. This was the cartoon that guided us initially when we were trying to encourage primary care to refer early. The concept here is time on the horizontal axis and inflammation getting more severe over time, but remaining treatable whenever you intervened. That contrasted with function, or you could see that as the reverse, as damage. So loss of function and damage was cumulative, so that at the time we were treating most patients, there was already a gap between what was possible and what these patients actually achieved. And this was then lifelong with a disease that wasn't curable. So 25 years ago, our concept was treat early before damage occurred. And that has stood us reasonably well since. And remission became the aim of therapy. I think it's now standard that what's once required evangelical lecturing, people now accept that early treatment is ideal and remission is probably the only outcome that's acceptable for a new patient treated at onset. And other things occur. The chance of remission is best with the first drug. So we've always suggested that use your best agent first, which is not the case even for guidelines now. And we've used the oncology analogy that you get remission early and then maintain it with less therapy. And I think, as I have said, remission for our patients is now a new patient presenting with inflammatory arthritis should expect to get into remission. So we'll look to see how well we've done with this. Well, here are some data. All of these are randomized double-blind trials. Some are single center, some are multi-center. But the striking finding is at week 2, 40% were in remission with a combination of biologic and a standard conventional synthetic DMARD. And all of these, on a treat-to-target basis, reached a remission rate of 70% or above. And if you looked at completers, it was actually much higher again. So undoubtedly, the use of optimal therapy at onset is very effective. The second advantage is that by getting patients into remission, you can actually reduce therapy. And this was a study we did 30 years ago, where the treatment period was patients were identified with what was then a novel MRI technique, and then they were treated with biologic and methotrexate for 1 year, and then were managed by their physicians for the next year. The first year was double blind. And what you can see is, and we're looking at quality of life and function here, these patients who had standard therapy did not actually improve much later, whereas those who had remission induction in this open period were receiving less therapy than these and actually maintained their good function and their good quality of life, showing the importance of early suppression of inflammation. And we also found that in most of our groups, we had about 10% who did really well. This patient actually, well, I think this is 8 years, yes, 8 years post their remission induction, remained autoantibody positive, had a high disease activity, but was now on no therapy and running marathons. So there is the possibility that you can re-educate the immune system. One of the studies I showed you earlier about remission was this one, the PRIZE study. And I use this as an example. At the end of a remission induction period of a year, patients were randomized to receive a varied tapering, which was either stopping the biologic, stopping all therapies, still with a 20% response rate, or halving the therapy. And it's clear that if you get patients into remission for many of our biologics, you can certainly safely halve the therapy, and in a subsector of those patients, you can actually stop therapy. So there's no doubt that by doing that, you can actually reduce the costs by using less biologic. And of course, the ligand is reduced when inflammation is less. And going back to damage, this is also from that PRIZE study, and it shows what happens when this is the phase 1, the open label phase, and phase 2, which is the double blind phase. And you can see this is the various groups showing the amount of damage that occurred. Now, normally you would see damage progressing even with biologic agents if they're used a little later. But here you can see there really is no damage in the double blind period, despite halving the dose, stopping it, and actually the placebo reduced its damage. So there's little risk of structural damage if you debulk the disease with remission induction, in this case with TNF inhibitor. And this placebo group actually improved despite being on no therapy at all. So the assumption is that if you really get down to very low levels of disease activity, a rather crude measure such as X-ray damage doesn't appear. And this is the most extreme example, an amazing study from Utrecht in the Netherlands. And what you see here is the initial responses. This is patients going into remission with an IL-6 receptor monoclonal, which is tocilizumab, with methotrexate, or as monotherapy, or with methotrexate alone. And even more surprising, this is sustained drug-free remission, which you see in about 40% of patients who are initially treated with tocilizumab and methotrexate. Now, the key here is these patients were treated in the first few weeks of disease, when probably they are susceptible to single cytokine blockade and total suppression of remission and re-education of the immune system. But there's a lot of antagonism to using first-line biologics, and these are some of the arguments. So we've been trying to get around that by identifying those patients who will achieve remission on methotrexate and targeting those who probably won't. And that's called the variety of things, including personalized medicine. And what we use actually are the frequency of naive T cells, which are probably a rather gross way of measuring the amount of activation within the immune system. And we know if you have normal T cell frequency, your methotrexate remission rate is about 4 or 5 times that of those that don't. So when we get a new patient, we do our biomarker, and it's about 50-50. If they have normal T cell response, they get standard treatment, and they would be expected to get remission in about 80% of cases. Now, this is actually a proof of concept study, so we do actually randomize the ones with abnormal results. We expect these to be about 50 or 60%, and that to be about 20%. But this was held up by COVID, as you can imagine, but it's nearing its completion. And if its predictions are true, we'll get about 70% remission rates, but with only half the patients requiring a biologic, which would answer some of the criticisms. The final advantage is that it avoids resistance. We have now a large resistant clinic where patients who will have failed up to 14 biologics or targeted synthetic drugs. And within that clinic, there isn't a patient who had the remission reduction regime, suggesting, but not proving, of course, that that actually does avoid this resistance late. And the mechanisms for this include probably, as I've mentioned, debulking disease, but by preventing an inflammatory drive, there's less push down other signaling pathways. And we know later in disease, there are multiple signaling pathways, and we have shown there's reduced epigenetic change as well, which may well be important. So patients go from being responsive to a single cytokine blockade early to requiring much more complex blockade late. So our expectations, well, I think early intervention, if you treat early, you do avoid damage. We have seen higher remission rates. We have permitted tapering, and less convincing, but I think is still likely that we do avoid resistant disease. And finally, I'll just say a little bit about really early intervention. As was mentioned, periodontitis is a key initiating factor in rheumatoid. We've shown that it's largely due to P. gingivalis, and it precedes any joint involvement whatsoever. It was always thought it could be disability that was the problem. We also have changes in the lung, some due to smoking, but again, pad activity is present. Of course, P. gingivalis can citronellate proteins, and it has an endocitronellase, which could change the proteins to allow the anti-citronellated autoantibodies to occur. And we've shown quite clearly that there's dysbiosis in the gut in the same patients, and the phyla of those changes in the gut actually associated with those that progress to rheumatoid arthritis. And we've had this sort of model of the continuum of rheumatoid with shared epitope, smoking, producing autoantibodies, then gradually moving along the spectrum to clinical arthritis. And that was our model 10 years ago. What we know now is that we have this first hit where there's localized autoantibodies, which then, if they're allowed to persist, produce systemic autoantibodies. We have non-specific symptoms, and importantly, we've just recently shown that the extended autoantibody profile occurs at this stage before there's even any subclinical disease. And we have, therefore, because these are the patients we can identify with this extended autoantibody profile, which we do on our national program, at this window of opportunity before there's any involvement, and that's including ultrasound or MRI evidence of involvement. So intervening at this stage, one would hope, would prevent even subclinical joint involvement. And with an even better opportunity, because the first thing that happens isn't the joint itself, but the periarticular tissues that get involved, as again has been recently shown. So joint involvement is very late in rheumatoid. That's our model in 21. So rheumatoid is the end of a continuum. The phenotype of the individual should decide therapy at each stage, and this should include precision medicine if you can, and it provides potential to intervene to halt regression before joint involvement. And most expectations have been met when correct approach used. And finally, something which I didn't think was going to happen in my lifetime, that blockade of inflammation with monoclonal antibodies may well be cost effective. What I've shown you is those results of using a biologic DMARD for 12 months with remission induction, and we'd probably do it for around 90%, but if you did biomarkers, perhaps only with 50%. The alternative is what we currently do if we follow NHS guidelines, is treat them with conventional drugs till they have a level of disease activity. And currently we're treating about 60% of our patients who go through this pathway, and these patients never come off the biologic. And for 100 patients, the cost of that, if we assume that a biologic for us is around £5,000 per annum, but our cheapest biosimilar, adalimumab, is actually 2,000. So we have the opportunity. First-line biologics could be cost-effective, and also possibly, I'd suggest, quite good medicine. So thank you very much.
Thank you very much, Paul. It was really a really great talk, and there are already some questions from Rani Sonen. So I'm not sure if we diagnose a patient in this early time window for psoriasis, it can take years before patients are properly diagnosed to start of biologic therapy, and may not be as early as we think or believe. So the question behind is when, you alluded to that, when is the window of opportunity to hopefully not only prevent tissue damage, but increase the likelihood to have durable, complete remission, and eventually without drug therapy. And that the second question, are there some identified biomarkers for these patients who will do well after treatment withdrawal so far in joint disease? These are the questions for you.
Well, there's a number of questions there. I think our interest in psoriasis is slightly different because our main ambition is to stop psoriatic arthritis, but we've also been interested, and I think Liv is going to talk about this, skin memory and whether you can avoid that by early, very aggressive therapy. And there's in this month's Annals of Rheumatic Diseases, there's 3 articles or studies showing the benefit of early intervention with long-lasting outcome benefits, way beyond that, in psoriatic arthritis, way beyond just the period of time of treatment. In terms of predicting who's going to do well and remain in remission, it's fascinating because it's sort of the reverse of what happens at the beginning. At the beginning, you have autoantibodies, then you have detectable changes in the joints, and then immunological abnormalities such as the T cell changes. And when you get patients better, they do it in reverse. So they actually get rid of the joint, then the immunology. And the patients who have normal immunology, and we have a remission which is called multi-dimensional remission, which includes the imaging and the immunology. And if they have those, they have a very good chance of being able to stop therapy. So it does appear you can, to some extent, and I wouldn't overemphasize this, but if you treat early enough, to some extent, re-educate the immune system to have its own homeostasis.
Thank you, Paul. Thank you. And that's something we can discuss at the end of all speakers' talk, because that would be very interesting to have a sort of a cross vision. There is a very practical question. I'm not sure that this is really the focus of your talk. Is the PEST, the psoriasis epidemiology screening tool, enough for screening of PSA? How frequent should the screening be? Maybe, do you want to discuss briefly?
We use the PEST all the time in our psoriasis patients. What we're not clear, actually, because the patients who are PEST positive then get ultrasound as a routine. And we're just gathering the information on how prevalent subclinical diseases in those who score normally on the PEST. We can't give you those data yet, but we certainly use the PEST, and we think it's very valuable. I think the proof that PEST negative is safe to leave alone still remains.
Thank you so much, Paul. And again, thanks from the dermatology community, and we cherish this close relationship with the rheumatology community.